general vicinity here of her tibial tuberosity. And this piece right here is when all your collateral ligaments within your stifle come in and attach right here. Okay. And on her left,
ready.
This one, I keep getting a view that looks like we have a notch that, there is supposed to be a notch here. Mm-hmm. It's not supposed to be this rough.
Okay.
Mm-hmm. And have this increased density right here. And that is where I keep trying to pull it apart to look at it better. Because this should not be here.
Okay. This is the left side.
This is the left one. The right one, and I hate to get rid of my motion shots because ironically sometimes in the motion ones you'll see something a little differently. And again, there's just this opacity right here that I just shouldn't be there. And again, the left one, we keep coming back to this little spot right here that makes me very, very suspect.
An OCD or you don't know
actually, yet? More or less I'm worried that she actually tore a cruciate ligament.
Oh, okay.
And it is what stabilizes your joint.
Okay.
Right? So it would be like tearing our cruciate ligament.
Yeah.
Okay. And so on those, when they tear those, it can destabilize the joint. So is that why we're seeing why she's having such a catching problem, so much worse on the left than the right? So what I'm going to do, we're going to send these off to radiologists and have the radiologist read them to see if they feel the same way I do or not. But this is the other side, and see how clear that notch is? You see just this nice dark hole?
Yeah.
I cannot get a hole on that left at all.
Okay.
And that is where I'm just a little suspect that we do have something there. See, again, just that little bit more opacity there that I don't see on this one.
And that's her right one.
This is the right one, the more normal one. Mm-hmm. The left side is the one that I'm seeing this abnormality right here.
So in theory, the right one could be a weak stifle.
Correct.
And the left one could be...
that would structurally have something that is causing her discomfort, which is creating that. Mm-hmm. So one way to know on some aspects is to help us determine where the pain comes from is to do some blocks, which I can't do when she's sedated because I wanted to rule this stuff out because let's say if she did have something really scary, you don't want to block and then make her run around. Mm-hmm. So you want to start with something a little bit more simple.
Elbow.
Is that we can do a block. And the blocks show us do a couple things. There are 3 joints that make up the stifle joint. This is her patella. This is what keeps catching. There's definitely some irritation along the trochlear ridge here. There's a lot of fluid in this joint too. But this joint, this what we call the dorsal, also communicates with the medial, which is the inside. In a healthy horse, where everything functions normally, it should communicate. When you start getting an inflammatory or a disease process, sometimes they're not going to communicate anymore, right? So a block may tell us a lot, right? If I block one spot, it doesn't change the lameness, then we move on to the next spot and see if I can change the lameness of it to see how significant that change is or is not. The problem of where that change is, it's in the center.
Okay.
So, which means it is without the joint capsule. So the joint capsule is going to be partly involved with the tuberosity, but may not include all the tuberosity, right? So my block can be a little not perfect, but if it makes a big difference, then we know which joint we need to go after because it's the one that causes her the most pain. Based on what the radiologist says, then I may actually send these right over to the surgeon and actually see if it's actually something that would actually surgery be the best way to go to give you the best prognosis, right? To get her to be comfortable and happy to
Yeah.
do the job, because that's the hard part. When you start with something this young that's already this unhappy doing something very simple, then, you know, would that be a road we need to go down to? We probably will need to block it before we have a good conversation with a surgeon.
Yeah.
But I do really want to hear what a radiologist has to say about that tibial tuberosity, because it's a little odd.
Yeah.
You know, I mean, I see a lot of films come across my desk, so when it's like that moment of like, God, that is not, it should be much clearer. I just can't, and that's one of my frustrating, I think it's a little real, is no matter what shot I take, it's still there.
Okay.
Right? Like every little angle variation.
It's not something in the way. It's
exactly.
something.
I think it's something there.
Yeah.
So, and that's what I want to know is what do they think it is? Yeah, I have an idea what I think it is, but I'd like somebody who looks, but that's their job.
Yeah.
Okay.
Yeah, you know what I mean? Where they look at a lot of films to tell me if that is.
And I don't want to speak for you, but I think if you're like me, you'd be happy if she's block sound for trails and stuff. Like you're not looking to jump her and
Oh, no, we just need to figure out something
like
for her.
Yeah.
But I guess why I'm bringing up in the order I'm bringing it up is a lot of times when you talk about joint disease, ironically the surgeon needs to come up as an early conversation, because our best success is early with a surgery.
Okay.
If we choose not that route, it's not a big deal, but it makes it very difficult to come back to it.
Gotcha.
Right? Okay. So the reason, that's why I want to bring it up is that, you know, based on sometimes, a lot of times I hate to admit, on that cycle, it's a very big joint. It can be very, very difficult to image all of it. Surgery still is the gold standard to go in and look to give you 100% of a diagnosis. And a lot of times these, we go in to clean them up. So if they have a big tear, then you go in and actually clean them up. So I think what we'll do is we'll get these sent off. We may have to plan another appointment to actually try to block the stifle. And there's also an advantage of blocking it because it puts fluid in there for me, which then I can ultrasound it a little bit differently. So if we, I might highlight a tear, so I can see it flopping in the breeze, kind of a situation with more fluid in the joint.
Okay.
When there's less fluid in the joint, sometimes it's a little harder to see some of those images. So sometimes that'll give us a little bit more clarification of me putting fluid in there to be able to see a little bit better.
Okay.
And then knowing how she blocks also will give us a little bit more information, right? So if I do the medial joint and it doesn't affect her at all, and I just do the dorsal joint, well, maybe the scarring is old.
Yeah.
And it's actually not necessarily physically bothering her as much as what I'm seeing on the radiograph, right? Because, I mean, there was stuff of her history we just don't know. So, and so that makes things just a hair bit tricky, right? So, if the radiographs were clean today, this is why I wanted to start with this. If they were clean, then to me it would be a discussion of, hey, do we try putting a therapy in there and see how she does? Or do we try hormones and anti-inflammatories and see how she does with that? But right now, I think we kind of need to, let me get these off. I should hear back in a couple of days. I'm usually really quick about the radiologist getting back to us. Usually 40 to 72 hours I get an answer. And then we'll plan on, hey, do we block her and then go from there? To help pinpoint the area based off what they say.
What is
And
surgery?
if the surgeon comes back and says we should just go in and take a look, then that is our first step.
It could
Would
be our
that
first
be
step.
a pill check or a WSU visit?
It depends. It depends a little bit on your comfort and.
We like the budget at WSU.
Yes, but then you have to include your budget as a trailer.
Yeah.
So I have to admit, majority of the time it actually ends up being pretty equal.
Okay.
The beauty of pill check is for us as a referring aspect, we get to be extremely involved. So communication and aftercare is a whole lot easier. WSU's communication is poo. So I hate to admit.
That's my next client.
I think it's my door. The doors on the truck is actually we were freaking
Oh,
out.
maybe. Yeah, he
Yeah.
just got here.
Yeah, but that's what
Guys,
I suspect is actually that the doors are flipped up. A couple of us.
It's gonna take flight. That truck is gonna fly away.
Yeah, exactly. WSU and actually OSU ends up being, I feel like a lot of times Dr. Huber is a little bit better about communication. The problem is when we do WSU and stuff, sometimes on those cases when it's a referral hospital, you lose control. So it can be a little frustrating. Yeah.
And getting over the past now would be not ideal.
Either ways, I mean, OSU would be a little easier right now if you have less weather.
Yeah.
But WSU right now to get over is is really tough.
Yeah.
Yeah. So, and then you, a lot of times what I'll do is start with pill chuck, get the quote, and see where we are, and then we can go from there. I know the surgery, yes, is going to be less at WSU, but by the time you add the hauling in and all that, it adds up. And the amount of downtime. Your guys' travel time too, depending on what you do. Whether we just put her in a hauler and she should tell you guys aren't
I
going.
would probably haul her.
Yeah, or going over. It's still days worth of time, so it can be. And most of those schools, like when we talk to these guys, a lot of times they're going to verify that the horse is lame and when it fits the history, they're not going to repeat everything. WSU will repeat everything. And so the hard part is a lot of times by the time we get them to the referral hospitals, they've been laid up enough. So the original reason why we sent them looks better. So then they'll tell you guys, oh, it's not that, and they'll chase some other thing, and then they still missed why the original reason why we sent them.
I'm hearing you say that pill chuck would be your recommendation.
As a general
Okay.
rule. Yeah, yeah. Unless there's one other thing, one other place I will send to, but it's my choice for soft tissue injuries. So we'll see what the radiologist says.
Okay.
Yeah.
Sounds
But
good.
I have to admit, pill chuck sometimes just ends up being easier. I'm not gonna lie, when you add the whole cost together, it ends up being about the same, and then they're here. They're
Okay.
local.
True. Yeah.
Yeah.
Okay.
And they communicate well with you?
Mhm.
Okay.
Yeah,
Yeah.
absolutely. Yeah.
Okay.
Way better than WC or OSU does. So.
Well, thank you for
Yeah.
watching her and.
Yeah, so and I think that's really a little bit of the anger and stuff that you guys are seeing. It's perception of work, right? And so to me, it's like it would be the saddle if it wasn't the surf single, right? If you never put any training aid on her, she's still going to do the same behavior. You're just stopping to create a pattern and a routine, and that's why she gets weird about it. If that makes sense.
She's such a social, like friendly horse.
Yes.
And it's not.
Yes.
She shouldn't be acting
Yeah.
this way.
No, but it's perception it's going to hurt. Is
Yeah.
why. Does that?
Yeah.
Yeah.
So it's the anticipation of the same routine happens.
Yep.
Yeah.
You know, I bet you, ironically, it may be a little less if you put the surf single on somewhere else. It may not be as bad as it when it is when you put it on in here.
Yeah.
Because this is where the pattern starts,
Yeah.
right? So, and these are sometimes the ones we got to change it up. Even after we fix the problem, sometimes it takes a little bit to go over the behavioral part of it because it becomes learned, right? So then we got to work on, let's change up the pattern and try to make it so that it's not a perception it's going to hurt to do the job.
Yeah.
Yeah. So, and then the hard part is they can only complain so many ways.
I know.
Yeah.
You know, that's the hard part. They can't
Yeah.
tell you no, so that you start misbehaving to tell you no.
Yeah.
So, and I think that's it. You know, because I have to admit, her patience level has improved immensely since you got her. I mean, immensely. You know, so she's come a long ways, and just knowing what she's supposed to do, what's expected of her. It's come a
Tries
long
so
way.
hard.
Yeah, exactly. You know, I think her front feet look better. The angles are staying nicer and more true. You know, and that's the hard part is I want to see what the radiologist says about that weird spot. The last horse I've seen this on was like a 24-year-old, so it's not as common of a finding. That's where I want to hear a second opinion on it.
Okay.
Gotcha.
Yeah,
Awesome.
yeah, on a
Hopefully that-
pacer.
Provide
So-
some answers.
Exactly, to help kind of figure out where we need to go
Yeah.
on if they feel it is what I'm seeing, then we will block her, and that will help open up the caveat of how do we want to handle whether surgical exploration is
Yeah.
what we need to do, just because, and it's okay if not. There are treatment options that are not surgery. I just know that sometimes we need to have the surgery conversation just a little early so I know where everybody is,
Yeah.
and
Yeah.
we can go from there.
Okay.
Could the surgery potentially be cheaper long term
Correct.
than
Yeah.
doing a
Correct, and that's also why I kind of wanted to find out what everybody thinks, because that may be
the better overall?
a better
Yep.
approach.
Z?
Okay.
Yeah,
Okay.
that makes sense.
Yeah.
Sorry,
Yeah.
'cause we covered a lot again. I always hate when we get these weird lamest ones because it's a lot of
Yeah.
information.
I'm so
Okay.
glad we had
Short
you out.
Yeah,
amount
me
of
too.
time.
Yeah.
Yeah.
I
Because there
appreciate
was a
it.
lot going on.
Yeah, and that's what you're seeing. It's what you're hearing. It's what you're seeing. Is
Yeah.
all about that patella. And I think you guys see it. And I don't know. I mean, you notice we kind of start backwards of most people, so we actually start right versus left.
Okay.
And not everybody. A lot of people have a pattern and a habit of how they do it. But yeah, I think that's why you guys feel it's the right hind, because it's actually worse going to the right, but it really
Yeah.
is the left hind.
Okay.
Okay.
Yeah.
I was like, she won't bend going to the right.
Yeah, she can't.
And
she
then-
literally can't actually.
But-
Yeah, because it catches, so that's
She's
what's
like,
creating
"Damn it,
why she
Clarissa."
can't actually bend.
With surgery, she could potentially be at a place that I am wanting her to be, which would be a trail type.
That's would be the
Fun
goal,
situation.
and
Okay.
that's part of what the goal would
Nothing
be.
more than that.
I don't know.
Okay,
I'll be able to answer that better in a
that's
little
fine.
bit.
Yeah, okay,
Yeah,
okay.
yeah. The hard
As
part
is
is a general
nothing.
rule. So this is the hard part. Is a general rule when we talk about orthopedic diseases in a joint and we talk about surgery. The goal is to get them back to the level of what they were. The hard part is we haven't even started work.
Yeah,
Yeah.
okay,
That's my worry. And so that's where my little hang up is yet, is that really she's so young.
Gotcha.
Yeah.
Okay.
That's my hard part.
okay.
Okay.
Yeah.
Yep.
A lot of these, when they're talking OCDs, where they're the big hole, and then a lot of those, yeah, we do surgery really early on to clean it up because it's going to give them the best potential, and they do a lot of those have great careers. And they go to do whatever we want them to do. They may not be an elite at the top of their game, but they can do a lot of it in between with ease and no problems. And maybe eventually they're going to have arthritis into their teens, but they have many years that are not a problem at all. Yeah.
Okay.
Yeah.
Sounds good.
Yeah, so I definitely want to have somebody's opinion of looking at
Okay.
that spot. So
So until we hear back, we're safe to hand walk her, don't
hand,
lunge her,
don't lunge her. I'd hand walk her.
avoid hills and.
No, I think actually walking up the hills would be great. I
Okay.
would avoid if there's any way you can go up a hill
And knock
then
her down?
Exactly, and find a
can.
different way down.
Yeah.
If that makes sense.
Yep. Down is really,
Very
really hard
difficult for her.
Yeah.
Yes, absolutely. So I would love if you guys can figure out an up and then a
We can,
gradual or
actually.
a different way down the hill.
Yeah.
And then you can always come back up it or whatever. But yeah, definitely keeping the walking, keeping the hills. I'm fine with a walk on the lunge line if she'll just be good.
Yeah, she will.
Just walk with her on the big line and make her, behave and do things and that kind of stuff. Let's just avoid the trotting for a little bit here until we know what's going on.
And any type of rails or side pass or
No side
off on
passing
all
at
of that.
all.
Okay.
I think let's hold off on the poles until I know what's going on in there. Normally, yes, I would have you guys start walking
Okay.
poles because that would help build up those muscles. But I'd like to
Yep.
know,
Okay.
as bad as she's catching right now, I'm actually worried that amount of flexion is actually going to create more inflammation. In the
Okay.
knee.
Yeah.
So I'd like
Got
to
it.
hold off on that for
Okay.
about a week here.
Okay.
I'm
Got
hoping
it.
we'll have a plan here in a week.
Okay.
Yeah.
Yeah, that's what I'm really
Great.
we'll have a plan or a goal or something we're going to look
Just
at
waking
here.
up.
Yeah, she is. She's a good girl, though.
Thanks, Jody.
Yeah.
Well, I'm gonna go
Appreciate you.
find Miss
a little
Karen.
a little